system or reimagine something new? Will healthcare ever serve consumers just like me and you? The power's in our hands, but every side's gotta come together. We want the newer generations to get something better. Until we flip the script and talk about what gets prevented. Until we see the changes permanent as if we meant it. Until healthcare is finally consumer-centered. We've got a lot to rap about. Welcome back to the leading podcast about consumer-centered health. This is more than a show, this is a mission, y'all. As healthcare leaders, we're here to share with you the latest consumer-centered ways that healthcare is being designed, marketed, and delivered. And as consumers ourselves, we want you to understand how these options work and why they might be right for you and your loved ones. Here's what's going down today. First up, our newest shout-out goes to healthcare marketing and digital teams, the engines behind digital front doors and patient growth. Then we wrap up our series recorded live from ViVE in Los Angeles. Today, we have a full lineup from health IT and health tech solution providers who spoke with me on the exhibit hall floor. First up is John Kirkman, VP of Government, Healthcare, and Education at Island, who shares how the AI conversation is becoming more operational. Next is Charlie Harp, CEO and founder of Clinical Architecture, who encourages health data suppliers to get out there and improve the quality of their data. Then you'll hear from Dr. Nancy Cibotti, CMIO at Heidi Health, who discusses how the company's hit the ground running in 2026. After Nancy, Ovatient CEO and founder Michael Dalton discusses trends in self-pay and virtual first care. Then we conclude with the team at DexCare discussing the real challenges for health systems when they look at access and capacity. You'll hear from CEO Matt Blosl, Regional Directors Tim Collins and Michael Murphy, VP of Commercial Operations Bryce McGee, and Kory Booher, Southeast Director of Partnerships. I'm Jared Johnson. Let's get it. Today's shout out goes to hospital and health system marketers and digital teams, the folks inside legacy organizations trying to modernize from within. Besides being our original audience, we're glad you're listening because your job might be one of the hardest in healthcare. You're balancing brand, growth, access, compliance, and patient experience, often with limited resources and a long list of stakeholders. You're expected to deliver consumer-grade experiences inside systems that weren't built for consumers in the first place. You're navigating legacy tech stacks, internal politics, and shifting priorities while still being asked to drive measurable growth and loyalty. And you're doing it in an environment where the cost of getting it wrong feels very real. Healthcare Wrap exists for people like you, and we're continuing to be here to show you the progress that you're making and that it matters. Every improved pathway, clearer message, better access point, and more human digital experience is a win. Thanks for sticking with it, sticking with us, pushing for change, and showing up for patients and communities every day.
One of the biggest things is the topic of AI and the question of how do we embrace it? What do we do with it? What are the opportunities we can take advantage of? But also, what are the risks? One of the things that Island is really good at is understanding the end user and understanding what they're doing with that information. So if you were to take some proprietary information, can you go paste that into some AI engine? The answer is we have controls around how to dictate that flow of information. Likewise, information coming in. How can we make sure that nothing's getting in from the outside that we want to disrupt our organization? These are the topics we hear coming up often. And one of the keys to this is not trying to make a decision on which AI is going to be the winner, but laying down the infrastructure that will protect you whether you decide to make a different change in the future. You're going to have that flexibility. So it's really about choosing a partner that can help you, with the long term and with the short term. Simplifying security for clinicians while ensuring data privacy is a big topic. We hear from large and small alike. The challenge that we have is we want to be able to make sure we put the appropriate guardrails in place, that we're helping move data where it needs to go, help people to do their job, enable business. We all know that we want to spend the most time possible with the patient. So if we're spending a lot of time logging on to multiple screens, it not only is frustrating for the clinician that's on the floor, but it's also taking away time from the patient. How do we help streamline this? How do we do things that ensure enough security that we want, but have frictionless access to the things that we need to do our jobs on a daily basis? So things like tapping in, tapping out, you need those integrations to work across your application stack, whether it's the EHR or you're bringing up other applications you need to help that patient along. We need to be able to do it in a streamlined way without creating any extra steps. We need to make it faster, easier, and secure at the same time. So the need to support legacy and modern infrastructure. I mean, we'd all love to just move forward with a clean slate and adopt the newest things, but a lot of organizations have made a lot of acquisitions of different technology over time. And anybody that works with healthcare knows we like applications. So we have a ton, and some are modern, many are not. So one of the things that we had to tackle when we got here was, yes, if it's SaaS-based or it's cloud-based, these are very simple things for us to ingest. But how about things like being able to take critical applications like the EHR and making sure you're certified to be able to support those applications. And then the next thing you've got to deal with a PACS application for somebody that wants to review images at home over the internet. Pretty complex and diverse set. So you really have to be able to do both. And that's weave in the aging technology as you bring in the new things and make sure that they can all work together seamlessly. And that's one of the biggest challenges we've been trying to tackle as of late.
So when you think about the things we want to do with generative AI in healthcare, AI is trained on data, it's prompted with data, and so it's very, very dependent upon the quality of that data to make good decisions. And that's not just an AI thing, that's all things. People rely on good data to make good decisions. Old school analytics, like back when I was a boy, digital quality measures and AI, all of those things require quality data. Now with AI, the big difference is the scale of what we're talking about. In the old days, we could get by with low quality data because a human could intervene in time. But as we scale the rollout of some of these generative solutions, it's going to be happening too fast. So we have to ensure the quality of the data is right so that we don't make tragic mistakes. So the PICI framework, the Patient Information Quality Improvement Framework, was an idea I had about 2 years ago when I was doing a presentation of all things. And it since has evolved into a way where we as an industry can start objectively measuring the quality of the data in a way that we can check each other and we can make sure that not only is the data good, but if the data is not good, we can explain why it's not good so that we can fix it. Because if we're going to be in this community where we're sharing data with the goal of improving patient care, we've all got to kind of do our part to make sure the data that we're sharing is good and usable by the other folks in the community. So the Pixel Gateway is our commercial scalable implementation of the PICI framework. And the idea is for our clients, whether they're payers, providers, or in life sciences, when they're accepting data or they're expected to accept data from someone else, it allows them to assess the data against their use case, determine if it's usable. And once it is, they can let it in the door. And until it is, they can give the feedback that your data is not really good enough for what I'm trying to do. And here's how you can fix it. It's really all about, like Lord Kelvin said, if you can measure something and explain it in numbers, you know something about it. But if you can't, then you're only kind of thinking about it as an idea. It's time that we in healthcare started measuring and understanding what we're actually trying to exchange. And that's what the idea of the Pixel Gateway is all about. I mean, the interesting thing that's happening right now, coming up on the CSM Quality Conference, is what just happened at the ASTP annual conference. And that is that there's really a lot of emphasis put on how we're sharing data. So it's less about the EMRs themselves and more about our ability to take data and use it, and also make sure that people are not doing information blocking. Now, my personal feeling is if you're sharing bad quality data, that's information blocking. Whether you don't give it to me or you give it to me in a form that I can't use, you're not really sharing the data with me. And there's a lot of emphasis being put on FHIR, on APIs, on our ability to exchange and leverage that data. Because I think one of the things CMS is really trying to do right now is they really want to be able to take tools like AI and use it to make sure that the money we're spending in CMS is being used for the people that need it and not some kind of fraud and abuse scam. There was actually a great fireside chat where Amy Gleason and Tom Keene sat down and talked about kind of how they're collaborating to improve how we exchange data, how we make the data usable. And when you think about what's coming out in HTI 5 and what could come out in HTI 6, a lot of it is about enablement, sharing, FHIR, and to reduce information blocking. I like that because data quality, poor data quality is really information blocking, for lack of a better description. And I think the other thing that CMS is really trying to do, by allowing it to be easier for us to share data, it's going to enable their ability to use AI and other tools to look for fraud and abuse and make sure that the money we're spending as a nation on CMS is going towards the people that need it and not going towards some scam.
What are we looking forward to in 2026? We are really excited to have been named a new vendor for KLAS. We have recently received an Innovation Award for Frost & Sullivan, and more recently, a new report shows us in the top 10 apps used by healthcare providers. So we are hitting the ground running and looking forward to expanding further. A few weeks ago, we actually announced Comms, which is our agentic agent. So that gives our partners the ability to do inbound, outbound calls, really taking some of the pressure off of our front care teams, being able to provide better care for our patients. That is fully customizable depending on what the needs are. And what we're really excited about is launching Heidi Evidence. So Evidence is a medical knowledge library. It is free to everyone. It is ad-free. So you can access that through our website, HeidiHealth.com. But if you're a health system and you want to customize that, we're able to provide that as well. And so we're excited to be able to offer this to our partners. Heidi's vision for healthcare is to be able to double the healthcare capacity broadly. So we've already accomplished so much with our AI scribe. We are in 190 countries. We transcribe 2.5 million visits per week. Total, we are over 100 million. So we are growing rapidly in the AI scribe realm, but we're more than that. We are a true AI healthcare partner in our platform with the Evidence launch as well as comms. We hope to be able to provide even more support for our care teams. We are looking forward to growing in all our markets, especially the US. We believe that, providing a more holistic view of an AI platform will help our teams provide better care by letting them do what they do best, and that's really caring for patients.
So Ovatient is really designed to be able to solve for 4 things. First is around creating access to a trusted health system by being able to deliver that through virtual care, high quality virtual care. The second is around care continuity. Oftentimes virtual care is really delivered in a way that's thought to be maybe episodic or one and done. And really for you to be able to provide and experience a high quality virtual care visit, it needs to be about care continuity, building a relationship over time that starts virtual first. The third thing is really around integration. So we're built on Epic, which really makes it for a deep integration between Ovatient and its customers. The fourth thing would be around quality. So for you to be able to really build the trust of a hospital or health system, we need to be able to provide high quality care. And if a provider there, that health system is referring to Ovatient and to a virtual experience, they need to know that our team is able to see a continuous care record, that they're able to follow up on maybe a visit that they started. So it's really being able to provide a high quality, aligned to the standards that a health system would expect, but we just happen to do it virtually. Virtual first care really honors a patient's preference and how they want to be able to receive their care. So when we talk about virtual care, that's really the modality. A virtual first means my first preference is that I want to experience that care in a virtual method. I want to be able to have a virtual primary care provider. And when I need to be seen in person, I have a trusted relationship with a provider who then's going to tell me, Jared, I need you to be able to go in and get these labs drawn, or I think it's best that we get you set up with an in-person visit for it's a referral into a specialty. And you're really leveraging maybe investments that health systems or investments in services that already exist in the community. For us, virtual first, I define it as being virtual first, local always. For you to be able to provide really high quality care, you need to know what resources are in the community. You need to know if a patient has a social determinant of health that's keeping them from being able to maintain their health. And so that's how we define virtual first care. Oftentimes we hear virtual care teams, or maybe it's somebody who's leading digital experience, and they talk about we need to have a digital front door. And at Ovatient, we talk about really having a digital health home, one place that patients can be able to come, get the care that they need from a trusted care team, the content that might be necessary in terms of being able to help them understand their condition. But we're really starting now to think more about, as we think that analogy, that really it's almost the digital front porch. And that's when we're looking at AI and being able to engage patients with or patients are using it to engage with questions that they might have about their condition, almost using it as like a triage, maybe a playbook for that conversation that they want to have with the provider. I've used it even in a way to be able to help my parents be able to prepare for a visit with a surgeon, and not knowing what did this image look like. So that's kind of, I think you're going to see this, and I heard a lot about this at ViVE, talking about the role of AI. It really, I think I like to call it the digital front porch. So recently I was at the inaugural Stanford Consumer Health Conference. I loved being able to kind of hear the progress that a number of these companies, say like Whoop or Aura, and what they're able to develop. Oftentimes though, it's cash pay, or people are still not covered by insurance. And that's one thing every single panel talked about. how they need to be able to democratize care. And that's one of the things we talk about Ovation is that we're democratizing virtual care and direct-to-consumer care is because for patients that come to Ovation, they're able to either pay cash or they're able to use their insurance. And so I think that's what's really important, that too often these models and too often it's really been like not able to appeal to those who do have insurance or maybe even have their insurance. And we're seeing this so much now. People who are insured, they're underinsured. They're not able to afford the care that they need, that they want. And so they're still able though to pay for that from a cash-based perspective. So one of the things that I saw though at Stanford was, so what happens then when I have this great direct-to-consumer experience? How do I take that data and I then confer it or share that with my care team? Yes, you can put it into, an LLM or ChatGPT, Claude to help decipher that, but there still then is care that needs to come from it. And so I think what I really took away from that experience was we need to create an interface, and that's where virtual first care really begins. I think has a great opportunity is to help those patients who have that data, have that experience, maybe it's from a wearable, and then be able to relate that into their, with their visit with a provider.
The challenge within healthcare is that they're being asked to grow, but they're being asked to grow in a very different environment. You've got patient demand increasing, you've got costs that need to be cut within the health systems, and then you've got a challenging macroeconomic environment. So what we're finding is our health systems need to figure out how to do more with less.
I think health system leaders think they need just one more AI tool to fill out the roster, which probably isn't necessarily the case. I think ultimately what it comes down to is they need to be able to prove value, right? The emphasis has always been on ROI or IRR, but more than ever, I think the ability to show demonstrable value, top line revenue growth, and becoming a budget maker instead of budget taker is kind of the name of the game. And those are the health systems that we tend to gravitate towards and work with.
Well, inside health systems today, what they're finding is that they feel like they have a capacity problem, but that's not the full story, right? What they have is providers that are overloaded. They have, more and more patients coming to book appointments. And so they feel like they're in a capacity crunch. We need more doctors. But the reality is they need more optimization across the whole patient experience.
When you think about deploying a technology, we want to make it easier for patients. If it's not actually easier for patients, if we're not actually saving money, if we're not improving margin, well, now that just sort of snowballs. We don't have line of sight into what the demand is for our services. And if we don't know what the supply of those services are, we don't know who the providers are that can actually offer that care to patients, well, now we have a total mismanagement of the actual economics that are going into the delivery of care.
What's actually broken underneath is scheduling. And the reason for that is it's built in pieces, right? You have the website that provides one view, the call center that provides another view, and then often the front desk that has its own view. And so the challenge is patients they come to book an appointment and they see that there's no availability when in reality there is. So the challenge is really getting a holistic view of demand and capacity and being able to match the patients with the right capacity.
The interesting part about access from my perspective is every health system's unique needs around access are different, but there's a lot of commonality across an SSM or a THR or an El Camino or an MUSC. And what we've been able to do is really identify what are those commonalities and help organizations see it from a different viewpoint and perspective, but nobody has access figured out.
At DexCare, we're a patient navigation company. We work with our health system providers to really connect the capacity with the scheduling and the patients that are coming in. Think of us as the matching logic that allows them to book appointments and see the results effectively. And most importantly, we do that across all the different scheduling avenues, whether that be the website, the call center. And it's a critical role that we're playing because of the fragmentation that exists within all of the healthcare systems today.
What changes with DexCare? We call it growth by design. So what that means is you can implement localized strategies, you can share institutional knowledge, you can basically book and schedule and grow into the areas you have capacity for inside of your health system at scale. So we can help everybody from your marketing department to your patient solutions team and the call centers book patients more effectively and route them to the right places and make sure that they get in the right spot.
We see incredible results with our health system partners. We're fortunate to work with large health systems like Kaiser Permanente, Providence, MUSC, Piedmont, and all of them care deeply about patient access. And so we've seen incredible results in terms of increased bookings and appointments to the tune of 40%. And so it's been really exciting to partner with such innovative and progressive health systems. And we've been able to drive those results in a very short period of time.
I would say the biggest value DexCare brings is that ability to match patients to that care with a much more frictionless experience. You've got to go to where patients are right now, and we have a bunch of modalities and ways we help health systems go do that.
This gets thrown around a lot in the industry. People say partnership, but with DexCare, what MUSC said is like they never felt sold. They never felt like they were sold a solution. They felt like we were partners and we built something together. You won't see our tool deployed the same way twice. Every system deploys it differently. Every system thinks they're a snowflake, and you know what they are. And we treat them like they are, and we don't try to shove them into our box where our product fits. We modify our product to fit the system's needs and priorities. But I'd say that partnership, true partnership, and not being salesy is why they like us.